a lot to be learned at my end also. And what is very important is, and I loved that model presentation that was made in the first presentation as well as made by Sir in the second presentation on the model of hernia. And I would want to share that when I was a third year MBBS student, I happened to read, I don't know how I developed interest, but I thought I was interested in surgery. And I happened to read about two parts of bowel getting connected to each other and wondered how is it possible. So open the surgical textbook and prepare the model at that stage with a towel. Looped top 2 towels, made an incision, used a sewing needle to connect to see how end to end, side to side, and end to side anastomosis were possible to be able to connect. The purpose of saying this is that one example was given in the first 2 presentations. I'm giving you another. Please try making your own model. Sir, I will be trying to present this information in ECON also. That we talk about all very costly models that are available nowadays. You know your anatomy, try preparing your own 3D models and see how you can enable the end results of surgery. Because you will revise your anatomy also like that. Coming back to the job that has been assigned to me, I'll be talking about approach to a patient of gastric outlet obstruction. Things are not always what they are scientifically. Now, gastric outlet is one particular part of it. Gastric outlet per se, can we have to specify? Okay, when we talk about gastric outlet anatomically, it refers to the pyloric antrum in the pyloric channel. But what it presents with is also presented in obstruction at other levels, say in the duodenum, second parts, above the level where the sphincteromoli is. The presenting features would be seen. So when we talk about gastric outlet and obstruction at the outlet, it is the syndrome of multiple clinical presentations. And before I go on to the next slide, I'll play a video which I have taken from the net only to show you a classical clinical appearance of a patient who has gastric outlet obstruction. And you can see a well-standing line moving from the left to right. This is very important because whenever there is obstruction anywhere, body lies totally obstruction at its level. And that can happen when the force of contraction of the muscle, stomach is a very muscular organ with 3 layers of muscles, as all of you know. And then the stomach, the peristalsis will want to, if there is an intraluminal obstruction, push it out. If there is partial obstruction also, the peristalsis intensity as well as the frequency would increase to be able to push out the contents from the stomach into the next part of the gut. Yeah. So what are those signs and symptoms that are there in patients who present with features of gastric outlet obstruction? And what is it that we should look for? These patients will have pain. Now what type of pain will it be? It will be colicky pain, which will be a gastric colic. And by colicky pain we mean it will be, can any one person stand up and tell me the definition of colicky pain? Anybody? One person. Yeah, who's speaking? Yeah, speak out. So one is one is it will be severe in intensity, it will be intermittent, it will reach a crescendo and have a deep crescendo effect also, and plus will be associated with vasomotor symptoms. Vomiting in these patients will be very characteristic. The vomiters will not contain bile if the obstruction is complete. Right? And after some time, when the stomach forcibly contracts, there is a little bit of paralysis that develops. So food tends to stay in the stomach. When it stays in the stomach, the bacteria act on it and it becomes foul smelling. So this kind of vomiting will be copious in amount, will be foul smelling, non-bile year when they want it out. There will be weight loss. Now, weight loss in these patients may be due to the pathology itself, which is gastric outlet obstruction, but this will present much later. Much later means it will take time to develop. But there may be a reason for weight loss, for gastric outlet obstruction happening, which itself may be a reason for loss of weight. And the most common malignancy in adults is malignancy, which is a common cause for gastric outlet obstruction. And it is pancreatic malignancy more than gastric malignancy. Gastric and neural malignancy is also cause obstruction, but when it comes to malignancy, it is this extraneural pancreatic malignancy that infiltrates the stomach, which leads to gastric outlet obstruction. Now, distended stomach may be clinically visualized and palpated. Your clinical methods will tell you various ways by which you will be able to feel a distended stomach. One is that on inspection, you will find that there is fullness in the upper part of the abdomen. Then I showed you in the video on the first slide that there may be visible peristalsis going from left to right side. Then you may be able to, by auscultative percussion, scratch the surface and auscultate with your stethoscope, and you'll be able to delineate the outline of stomach, and stomach can distend to the level of even pelvis. The shape of the stomach will tell you how much. It is a very extensible organ. It can reach up to the pelvis. Percussion will give you a hyperresonant note. There is a clinical test which goes by the name of saline load test, and by that you can make out if the stomach is obstructed in the outlet or not. 750 milliliters of saline is given, and then after about half an hour you aspirate. If you aspirate, you are able to re-aspirate 400 ml out of it. That means fluid has not been able to pass through the gastric outlet. This is called a saline load test. Then there are sequelae of metabolic derangements that happen in this, which will present in different ways, and those symptoms can be recognized. Electrolyte imbalance and dehydration will be crossing visible. Patients of electrolyte imbalance are usually very drowsy and their muscle movements are slow. And dehydration, or clinical signs of dehydration will be there. So when we talk about approach to a patient with gastric outlet obstruction, we are making an effort. I will be teaching very little. I want all of you to think like I talked about in clinical presentations also. We don't want you to mug up things. We want you to understand, one, that there is an anatomical obstruction in the stomach. There could be other reasons for obstruction. There can be functional causes for obstruction at the gastric outlet also. Right? So we will be doing some investigation and clinical tests to find out what the possible cause could be. And then in treatment, each one of these patients needs to be optimized before any definitive management is done. And what all this is about, we will talk about in the next few slides. So in any patient whenever you are asked about a cause for anything, keep this acronym centers in mind. You don't have to write it like acronym. Keep it in your mind and think of possibilities that are congenital, inflammatory, neoplastic, degenerative, endocrine, result of trauma, or is there a systemic disease that is causing it. Most of the pathologies you will be able to identify everything in terms of these lines. When we are talking about obstruction at any level, think whether the cause of obstruction is intraneural, or extraneural. By that, you will be able to analyze. Keeping in mind gastric outlet obstruction, the possible congenital causes could be congenital hypertrophic pyloric stenosis. There can be Webb's lump. Inflammatory causes could be because of the pseudocyst causing a pressure. Tuberculosis is a big mimic of all pathologies. Peptic ulcer disease used to be a very common cause for gastric outlet obstruction. Now malignancy has taken the lead over benign causes. Neoplastic lesions may be benign or malignant. And when we talk about degenerative diseases, reservoirs within the stomach, Mersey syndrome will be called gallstone, which is compressing on the common bile duct or rectory viscera, and may erode into it or just compress upon it. Endocrine causes in with pancreatic tumors, resulting from a ingestion of caustics, post-operative causes, and diabetes mellitus is a common systemic disease which can lead to gastric acids. So what are these metabolic reactions that we are talking about? When there is prolonged vomiting, we have read about maintenance of internal body homeostasis in physiology. So this is what is called its body is going to compensate for whatever pathology is being caused by gastric outlet obstruction. When there is prolonged vomiting, there is loss of hydrochloric acid. When there is loss of hydrochloric acid, there is increase in bicarbonate in the plasma to compensate for the lost chloride. Because the total number of anions and cations must remain the same, they must balance each other to maintain the internal value of the body. Derangement of this internal value can lead to mortality also. So it is important body is trying to compensate by increasing the bicarbonates in the blood. Now, hypokalemic, hypochloremic metabolic alkalosis happens. What does this do? Because of this, intracellular potassium is shifted to the extracellular compartment. Now, serum potassium is increased factitiously. With continued vomiting, there is dehydration. We know that sodium holds on to water. So now body is trying to preserve sodium. Now how can it preserve sodium? If it has to preserve sodium, it has to push out something else. So in the distal tubules, it starts pushing out potassium. It starts pushing out potassium so that sodium and hydrogen ions are retained. It is the adrenocortical response to hypovolemia that there is an intensified exchange of potassium for sodium and the distal tubule. So the metabolic rearrangement that you find is hyponatremic, hypokalemic, metabolic alkalosis with paradoxical aciduria. So now how do we diagnose all this? Our aim of imaging is that we need to find out what the cause is, and we need to find out what exactly are the features in the stomach with respect to gastric outlet obstruction. So a plain X-ray will show you a distended stomach. A plain X-ray will show you something like a reservoir that is made up of hair and opaque. You may be able to see some kind of pathology on plain imaging only. By contrast imaging, it may be CECT. In today's day, very few people are doing very upper GIT, but that used to be a very common investigation that was done to diagnose these. And gastrocavity tests are there. Upper GI endoscopy is the gold standard, but for that you need a green stomach. If you are suspecting gastric outlet obstruction, you will need to do a gastric lavage before you subject the patient to upper GI endoscopy. Then image guided FNACs, any of these investigations are suggestive of some kind of a mass lesion in the stomach or outside it, then you may consider doing image guided FNAC. Now, pancreatic malignancies, you will not do FNAC, they are not really required. But if it is an advanced malignancy, their treatment may not be possible, you may think of doing FNAC. Then image guided FNAC may also be needed in those patients in which there is a metastatic disease and you are suspecting that this patient may not be possible to treat this patient with a curative intent. And radionuclides will give you a functional imaging, telling you how much is passing out of the stomach. To be able to treat them, it is mandatory that all of these patients undergo initial medical management for them to be optimized. Because the results of surgery will be dependent upon how well your patients are optimized. And this optimization, as a blanket rule, consists of hydration with normal saline. Why normal saline? Why not liquor-lactate? Very good. Because liquor-lactate is a soda bicarbonate content in it. So normal saline has to be given. Correction of hypokalemia needs to be done. Nasogastric tube decompression. How does nasogastric tube decompression help? One we have said that we clear the stomach. once the tone will come back, the outcome of your surgical results will be better. The medical treatment, if needed for, if there is an underlying pathology like peptic ulcer disease or H. pylori, which is the reason for gastric outlet obstruction, they can be treated. And then the initial medical management can also consist of balloon dilatation, not really practiced much by surgeons, but if it's a pliable obstruction, one can. The surgical procedures, just to tell you the name, a few names actually: vagotomy and tracheotomy, vagotomy and pyloroplasty, truncal and gastrojejunostomy, Ramsay's operation in children, and feeding jejunostomy as a palliative measure. Why vagotomy? In those patients in which there is peptic ulcer disease and you want to decrease the acid levels, vagotomy is done. Now, why anerectomy and pyloroplasty with it? Because whenever vagotomy is done, outflow from the stomach will be obstructed. So that has to be bypassed, and that is done by these procedures to loosen out the outlet of the stomach. Why gastrojejunostomy, not anerectomy and pyloroplasty? The morbidity of gastrojejunostomy is the least as compared to the morbidity of the upper two procedures. Ramsay's operation is done. What is happening in congenital hypertrophic pyloric stenosis is that the musculature is hypertrophic. Mucosa is normal. So once the fat is made in the muscle only without damaging the mucosa, the muscle tends to pop out and the obstruction is relieved. Feeding jejunostomy is a palliative procedure that can be done, but it can also be done to build up the patient's malignancy especially. So what is the palliation for obstruction? It can be surgical. It can also be done by placing stents endoscopically, and these stents may be metallic, upper metallic or self-expandable. We are talking about metallic stents here because we are assuming in most of the cases the obstruction is due to malignancy, and when the obstruction is due to malignancy, you prefer metallic stents over non-metallic. Why copper metallic? Because metallic stents have a tendency to infiltrate into the adjoining, so there can be complications like perforation and displacement. So covered metallic stents prevent this from happening, and self-expandable will be patent for a long time. The complications that happen, we will be talking about basic principles of a few surgeries after this. Complications that can happen may be stent related, which may be like malpositioning. When you put a stent only, you don't put it in the right place, malalignment. Stents may migrate. Tumor overgrowth can happen. And this also happens more commonly in uncovered stents than in covered stents. Bleeding and perforation can happen. In surgery-related complications can be nutritional, whether because of an anastomotic leak during surgery or due to the disease itself. And then post-gastrectomy syndromes like dumping, alkaline gastritis, and apparent loop syndrome. So what is apparent loop syndrome? So whenever we do a bypass, we need to have an appropriate length of the apparent loop. If the length of apparent loop is longer, then the emptying of the apparent loop gets affected. And this apparent loop keeps collecting the gastric contents within it. And when they empty out suddenly, it can also lead to dumping syndromes in shock. And the management of apparent loop syndrome may end up being surgical itself. So to create all these loopses properly is important. Now here, I've tried to show with the help of a few cartoons that what are the various things that can be done. One is that to be able to do a pyloroplasty, you make a longitudinal incision. Try doing it on any tube that you make. Make a longitudinal incision and you stitch it up transversely. You will find that the lumen of the tube has increased. So this is what is practiced in some forms of pyloroplasties. Reconstruction, you cut the part of obstructed stomach and the adjoining duodenum. And from whatever is left, the endostomach and the end of duodenum that is left are directly sutured to each other. Right? And then another thing is, if you keep those two ends closed, get a loop of jejunum after this increase the lumen there itself by working on the side. You cannot do it in malignancy. You will not make a longitudinal incision over malignancy and suture, you know. You have to select your patients. Because you do a benign pause and you think you will be able to achieve the same result to make a longitudinal incision with the suture and transfer. Now this will be my last slide, which is surgeryeducation. Is again a bypass procedure where the loop of jejunum is brought up to the stomach into anastomosis, and the other two ends is sutured. Now the rule by gastrojejunostomy, probably you will please correct it, it's not gastrectomy, rule by gastrojejunostomy. What is this rule? Rule? What is rule? What is rule about? So rule is a name of a surgeon, right? So he created this thing in which you transect the jejunum. When you do surgeryeducation, you just brought the loop up and anastomosed into stomach. And we did talk about abdominal loop syndromes also, right? So here then, after around 20 to 30 centimeters, the jejunal loop is fat, it is transected. Now after you transect, you will get with now two limbs of bowel. The distal limb of bowel is taken up to the stomach. This will always act as an enteral limb, which will be used for cleaning. There will be, if it has been anastomosed properly, there will be no obstruction here. Gastric outlet obstruction is not relieved. Now there is bile which is coming from the second part of the duodenum, which needs to go into the bowel also. So this limb, which is a biliary limb, is brought back and anastomosed to the enteral limb, and anatomy is restored. So once you are able to do it, to my mind, gastric outlet obstruction is relieved, and I will be open to any questions. Yeah. Please read as much as you want from your books and keep reading about various things or various imaging findings that you are getting. But remember the basics.
Geo, this is Ratna. Below to a ruined mind.
Sorry?
Which are these Ratna? Geo, ruined